All righty. Well, happy Friday, everyone. I'm happy that everyone is here and really excited about this interview here. I have a Dr. Angela Mazza, who is a triple board certified doctor in endocrinology, diabetes, and metabolism, as well as internal medicine and anti aging and regenerative medicine. So, Dr. Mazza's broad medical background includes significant research in both basic and clinical realms of endocrinology. And Dr. Mazza is the founder of Metabolic Center of Wellness. And is it I know you told me. Can you? I'll let you say it.
Oviedo.
Avito, Florida.
Yeah.
Avito, Florida, where she spends a great majority of her time caring for persons with autoimmune thyroid disease, thyroid nodules, and thyroid cancer. Highly regarded for her individualized approach to patient care, Dr. Mazza empowers each person to achieve their unique goals by providing education, lifestyle management, and support. And Dr. Mazza believes that hormonal changes that happen in women and men as they age play a huge part in their overall health, longevity, and quality of life. Her passion is helping her patients achieve metabolic as well as hormonal balance. And we're going to be chatting about radio frequency ablation. Again, I'm really excited, and thank you for joining us, Dr. Mazza.
Thanks so much for inviting me. I'm happy to be here.
Yeah, so let's go ahead. If we could start off a little bit with your, well, I gave you a background. So I guess really, how did you start helping people with radio frequency ablation? Because there still aren't a lot of doctors that do this across the United States. And I know you're currently the only one in Central Florida who does this procedure. So yeah, if you could talk about how long you've been doing and how you
Sure.
started incorporating this into your practice.
Sure. Well, I've been taking care of patients with thyroid nodules for years. And up until, a few years ago, this therapy, radiofrequency ablation, wasn't even available or FDA approved in the United States. So before that time, I was having to send patients to surgery for nodules that couldn't otherwise be treated. And unfortunately, going to surgery, oftentimes they'd end up on thyroid hormone replacement. So um, for things for something that really should have been so easy to treat. So RFA has been used for years for even here in the United States for different tumors like liver, lung, kidney. It's even been used for the heart and for varicose veins. But it wasn't until 2012 it was started to be used for thyroid nodules, believe it or not, in South Korea by Dr. Baek, who's kind of like the father of RFA for thyroid nodules. And it took that long with all the data that was happening, all the proven benefits that were going on for the United States to approve it. So once I started hearing about this exciting research that was ongoing all over the world, I was like, well, once this is FDA approved, this is something I totally want to be able to provide for my patients because I was doing thyroid biopsies, thyroid ultrasounds, and unfortunately, just having didn't have any choice for some nodules to have to go to surgery. So once it was available, I was like, yes, I have to be able to provide this.
All right. And I'm sure a lot of people listening are familiar with what thyroid nodules are, but I'm still going to ask you if you could explain what they are, how common they are, what are some of the causes or common causes of thyroid nodules?
Sure, thyroid nodules are super, super common. About 1 in 3 persons, sometime in their lifespan, is going to have some sort of thyroid nodule. That's how common they are. And there's nodules that have different kind of characteristics. Some nodules are more cystic and they become fluid filled. Some nodules are more solid and become and they're hard. Some are kind of a mix of both. We call them complex. And then there's nodules that are more concerning, which are cancerous. But the cause, that is a good question. What causes thyroid nodules? Up until recently, we always just kind of threw it off to iodine deficiency. And I think that's kind of an unfair blanket statement to say that all nodules are caused by iodine deficiency because all nodules are a little bit different. That just doesn't make sense. But what we're finding is that the thyroid is so sensitive to inflammation. So, and sometimes these nodules can be a result of inflammation in the body and then in turn cause inflammation in our thyroid. Um, Now, different nodules behave differently. So these cystic filled nodules, sometimes they just keep filling up with fluid and they become a problem. Sometimes nodules are just small and they don't cause any issue and we just leave them alone and just watch them. But every nodule, it's important to be able to characterize and say, all right, these are ones we can watch, these are ones that are causing issues, and these are ones that are suspicious. So I hate to say thyroid nodules are like snowflakes, but they kind of are. They're all a little bit different. So it's it's a tough question to answer to say what's the cause of them.
And when it comes to when you do an ultrasound and you detect thyroid nodules, and it sounds like maybe not all of them require follow up. It depends on the characteristics.
Yeah, that's a really good point. I mean, if some are really tiny little cysts, they have just fluid and they're just tiny and they have certain characteristics that we can see on the ultrasound, they might not even be worth following. So they're so benign. And there's a grading system that's been developed to look at what are the concerning characteristics, what are ones we have to follow more closely, what are ones we have to biopsy, and what are the ones that need to be addressed as far as either surgical removal or some sort of more proactive therapy.
So in my practice, I see a lot of people with both Graves and Hashimoto's, but I focus a little bit more on the hyperthyroid side.
Yeah.
And so, other than Graves' disease, we do see some cases of toxic multinodular goiter. So, can you talk a little bit about toxic nodules? And and again, we're going to get into the RFA, and can it help with toxic nodules? But if you could describe like what toxic nodules are, and maybe also, like for those who are unfamiliar with the term, like hot nodule versus cold nodule.
Okay. Well, toxic nodules are essentially overactive nodules. So these are nodules that are starting to make their own thyroid hormone and not listening to the signals to stop making thyroid hormone. Now, toxic nodules have a very distinct look on the ultrasound. They're really hypervascular. And that's what feeds into these nodules to make them keep being overactive. And in certain cases, can cause them to be quite large. Um, as far as therapies for toxic nodules, actually, the difference between cold and hot nodules, or a hot nodule is considered a toxic nodule because when there's certain imaging that we can order. I don't use this imaging as much anymore. It's kind of like not needed. But there used to be these scans called radioactive iodine uptake scans using these for toxic nodules. So say someone shows up with a nodule, we're not really sure what it is. So before biopsy was around, we would send them for these radioactive iodine uptakes. And wherever in the thyroid nodule it got taken up would be a hot nodule if it was a nodule. So it would glow, so they would call it hot. Now, they used to say nodules that didn't take up anything were cold and they were suspicious. They were, oh no, they might be cancer. We kind of got away from calling cold, non-functioning nodules suspicious for anything because we know that's not true. You do a biopsy, most of the time they come back fine. Hot nodules just kind of just light up. So we can use that term hot. But it also means toxic or hyperfunctioning. But up until recently, the only treatments we had for hot nodules were one, we can put people on medicine. So anti-thyroid medicines to really kind of to cool off that overactive nodule, especially if it's causing problems like symptoms of hyperthyroidism. So if someone's feeling hyperthyroid, they're feeling hot, they're feeling shaky, you're having trouble sleeping, having palpitations, all the symptoms that go along with overactivity. So the medicine can kind of cool that off. But when we're talking about toxic nodules, those, unlike Graves' disease, where sometimes we can get people off anti-thyroid medicine, toxic nodules don't tend to shut down on their own with that type of medicine. The second treatment is radioactive iodine. So just like that radioactive iodine uptake scan, a different amount of radioactive iodine is used to be taken up by that nodule and shut it down, or essentially just turn off its machinery. Sometimes that works. Sometimes it causes a whole thyroid to become underactive, which is a downside. Sometimes these people need another dose of radioactive iodine, but it is radioactive iodine still. That carries with it its own concern. And then surgery would be the other option, to just take out that side of the thyroid or the whole thyroid. But until recently, radiofrequency ablation has been a treatment option available for persons with overactive thyroid nodules. So it's kind of a new tool in our toolbox for hot nodules.
Yeah, which is awesome. And again, we're gonna dive into that. But one thing I want to ask you, you mentioned the radioactive iodine uptake test, and I still notice a lot of endocrinologists still use that. So it sounds like you stopped using it in your
I
practice.
can't even tell you the last time I ordered a radioactive iodine uptake scan. It's been, I want to say it's almost been 10 years because that's why ultrasound is so great. I have an ultrasound in my office. I say, okay, you've got nodules. Let's take a look under the ultrasound. If I'm looking at the thyroid gland, I see the nodule, there's supervascularity going on. It's a toxic nodule. End of story. You don't even really need to biopsy a toxic nodule because they're 99.9% always benign.
So I'm glad you mentioned the ultrasound and biopsy because I mean some will justify using the radioactive iodine uptake test to prove or not prove to again give hints if it's cancerous. But like you said, even if it's a cold nodule, it doesn't mean
Yeah.
that it's cancerous. Most of the time, it's not going to be cancerous. So why not just do the ultrasound and then depending on the characteristics of the ultrasound determine if someone needs a biopsy? And it sounds like that's the approach you take in your practice.
Yeah, and I mean, as a skilled ultrasonographer, I mean, you just get used to seeing these nodules, and you start to be able to see different characteristics. But yeah, those radioactive iodine uptake scans, they're a pain for the patients, and they're oftentimes not accurate. I mean, they're just it's not worth the time and energy.
Yeah. Thank you. I'm glad you mentioned that because I've been saying that for years. Just
Yeah, you were right.
yeah, try not to knock other endocrinologists who use it, but just not a big fan. I just don't understand why. Another reason why some will use it is to diagnose Graves' disease. But if someone has hyperthyroidism in the presence of the
What's
elevated
the point?
autoantibodies, like the elevated TSI, then we know they have Graves' disease. They don't need the uptake, for
No.
that. So there's like different reasons they give for doing the uptake test. But to me, it's just never made sense.
I mean, you could plead a case for like a thyroiditis versus Graves, but even then, you're going to see different changes on the ultrasound that you still don't need you don't need the uptake scan.
All right, so let's get into radiofrequency ablation. So if you could
Sure.
describe what it is, when is it indicated?
Sure, yeah. So I kind of mentioned that radiofrequency ablation has been used like for years and years for other things, but radiofrequency ablation is great for benign and toxic nodules or hot nodules. Um, So essentially, it's using a electric current to go directly into the nodule and causing tissue. I hate to say damage, but essentially it's agitating the tissue and it causes long-term ablation in the nodule itself. Um, it's great because it leaves the rest of the thyroid completely intact. You're only working on the nodule itself. Um, this procedure, as opposed to surgery, and there's surgery is great for some things and for many things, but this is done in the office. There's no anesthesia. There's no downtime from work. There's no thyroidectomy scar. Um, it's just kind of a nice alternative that we never had until recently here in the States.
And you mentioned just before that it could help with toxic nodules, which is
Right.
great.
I
Uh,
mean, some nodules are a little more challenging than others for RFA and they require more sessions. Toxic nodules, depending upon the size, since they're so vascular, oftentimes require more than one session, but still, I mean, it's it's a beats surgery and all that goes along with the possible risks of surgery.
yeah, so like a single toxic nodule sometimes will need multiple treatments.
Yeah, depending on the size of the nodules in general, I've been seeing some very large nodules, and you really can only ablate for a certain amount of time because you want to keep it within you want to wanting to keep it within safe time periods because you are dealing with electric current within the nodule, so you just don't want to over ablate. Um, but most nodules can be taken care of in one session.
Okay. One of the questions I had, which I think you kind of answered it, but I'll ask it anyway. If someone comes in and let's say it's not toxic nodules, but just larger benign nodules, maybe like 2-3 centimeters or greater, and they're endocrinologists, they're currently seeing an endocrinologist that's saying, hey, you just got to take the thyroid out. So if they need to get more than one nodule removed, typically it would be like one nodule per visit per session. Would that be fair to say, or it
It
depends on
kind
the
of
person?
depends. It depends upon the size of the nodule and the positioning of the nodule. If they're kind of on in the isthmus and on one side, we can try and do more than one at a time. If they're on both sides or bilateral, generally, um, depending upon the size of the nodule, I'll do just one side then the other because it's kind of it. I mean, it's a procedure. We're trying to be cautious of the patient's comfortability also because the patient is awake during the surgery. I usually give a little bit of anxiolytic beforehand just because it's kind of nerve wracking because you hear the generator going but we keep trying to talk the patient during the procedure. That serves two purposes. It makes me know that they're doing okay. Plus, it also helps me monitor their voice during the procedure. Because one of the things, surgery as well, is there's a risk of recurrent laryngeal damage. Very, very low compared to surgery. But as long as we monitor the voice, it's a good kind of gauge of how things are going. Plus, it gives me an idea of how comfortable they are.
Yeah, should someone who goes through the procedure, uh, should they expect to experience any discomfort at all, or?
Well, it's kind of like the biopsy, but a lot longer. So if you've ever been through a biopsy, your neck is extended. Um, Unlike a biopsy, deliver a lot of numbing medicine to the area. So we give about 10 milliliters of lidocaine. That serves a number of purposes. The thyroid itself doesn't have nerves, but the thyroid capsule has nerves, and the surrounding tissues have nerves. So when we inject the lidocaine not only numbs the capsule, but it also separates the structures of the neck out. So it separates out the carotid artery, separates, kind of protects the recurrent laryngeal nerve. So it serves multi-purpose. So to answer your question, the patient should not have discomfort during the surgery, but pressure is normal because I'm leaning on your neck with an ultrasound for up to like 30, 40 minutes. So we take breaks. Like I'll say, are you all right? Take a break. Plus the other thing that patients often comment on, because we're using it's a probe, it's not unlike a needle that's done for a biopsy, but the probe, as I'm using it, I'm going to systematically to different parts of the nodule and ablating each area. And sometimes they'll feel like a little pop because that's the thyroid tissue being ablated. It's a weird feeling. It's not more of a pain, but it's kind of unexpected if you're not aware of it.
Okay, and on average, how long does the procedure take? I'm sure it varies depending on the person, but
Yeah, in hold, before I would have to say from start where we do a baseline ultrasound to the end of the ablation, from an hour to an hour and a half.
okay, that's not too bad.
No.
And once the ablation is done, and let's say they just have a single nodule and they only needed that single visit, do they typically need follow-up visits after that to just monitor it?
Yes. Right after the procedure, patients really don't have any restrictions. I mean, you don't want to do any heavy lifting or anything like that for a day. But as far as the follow up, I recommend doing an ultrasound in about 2 months after with some repeat thyroid function tests, then at 6 months, and then at least at 12 months. And we have a lot of patients that come out of town for this procedure. So I'm reliant upon other ultrasound reports and ultrasound images to do follow up on those cases. It's nicer when I can do my own ultrasounds for follow up because since this is a new procedure, a lot of the radiologists aren't used to reading what does a nodule look like after it's ablated. So it can look actually suspicious to them because some of the markings that go along with suspicious nodules can look similar to where areas have been ablated within the thyroid. So that can cause a little confusion. That's why I like to do my own if I can. But as long as I have the disc to to really look at the images. That's part of the follow-up. So we tend to see the best results right around 6 months to 12 months, because even though we've ablated tissue during the procedure, that conductive heat is continuing to ablate tissues within the nodule up until that time period. The 2 month follow-up is just so I can make sure everything looks like it's going in the right direction.
Yeah, makes sense. And
Yeah.
speaking of suspicious nodules, I don't think yet RFA is indicated for suspicious or malignant nodules. Do you think that's something that maybe in the future that possible? I mean, because I have looked at we were chatting about this a little bit before we went live, that I've done my research, and I'm sure there's a lot of studies haven't read, but I'm pretty sure I came across like one or two studies where it showed it actually can potentially help with malignant nodules as well, at least in the research studies.
Right. The ongoing studies are super promising, especially and it's mainly, they're just looking at low risk papillary cancer. So, papillary cancer is the most common type of thyroid cancer. So, they're looking at smaller, like about 1.5 or less centimeter nodules and RFA. And it's been found to be as safe, if not safer, than surgery, and a potential therapeutic option. So, the results thus far have been really good.
And is there any chance or risk of the nodule growing back years later after removing it with RFA?
Yeah, there is that potential risk. I mean, we're trying to get everything within that nodule. Um, Success defined as far as the research study is a volume reduction of 75% at 6 to 12 months. So that's considered success of the RFA. So that holds with it if there is a little bit of thyroid tissue left, especially if it's one of those more vascular nodules, there is the potential for the nodule to grow back and you require another session down the line. But that's kind of the good thing of doing serial ultrasound. So even, doing an ultrasound once a year, you can stay ahead of this, and it would be less of a of an RFA procedure down the line. But ideally, we don't. That's not the goal. But I always let my patients know there is the potential for some of it to grow back, and and especially the toxic nodules. They're the most challenging.
Yeah. Well, I guess, I mean, everything comes down to risk versus benefits. And I know if I was facing thyroid surgery due to nodules, I'm pretty confident that I would go the RFA route. And I'm not saying that just because I'm interviewing you. I mean, just, the name of my podcast is, Save My Thyroid. And so that's my
Right,
goal. Just like you try to save thyroid. So, if I happen to have the nodule removed, and, I would hope it wouldn't grow back, but still, if it did, I guess still, I mean, I guess I would just consider having it again. But again, if,
right,
you have to consider the potential consequences of thyroid surgery. A lot of people have thyroid surgery and they do okay, but as you said, there's the risk of the damage to the laryngeal nerve, the parathyroid glands. And again, not
right,
that there's absolutely zero risk with RFA, but just in comparison to surgery. So I still think in many cases, I don't know if I should use the word no brainer, because I know it's not an easy decision when choosing for some people
right,
between RFA and surgery. And then there's we were also chatting where currently in most cases insurance, doesn't cover it. So, so they might have to pay out of pocket for it, but still, just in the day of high deductibles and being on thyroid
right,
hormone replacement permanently after getting surgery, again, you really got to look at the long picture and not just, even if someone's thyroid surgery is completely covered by their insurance. Again, I know if it was, and it's easy to say that I'm not in that situation, but still, I'm pretty sure I still wouldn't go the surgery even if it was 100% covered, and if I had to pay out of pocket for the RFA, just because of the potential consequences the surgery can have.
right. And just replacing your own thyroid with thyroid hormone replacement, it's tricky. I mean, not everybody feels great on the same thing, and I think it's a quality of life thing after. I think sometimes people make the knee jolt decision. All right, I just want to get rid of the nodule. I'm going to do the surgery and just take thyroid medicine for the rest of my life, but you don't think about the long term consequences. So I mean, even like the best thyroid combination, and I mean, it's not always, not everybody feels great afterwards.
Here, a question also that just came up, experience. So like, when if someone does undergo thyroid surgery, they probably want to choose a surgeon who has a lot of experience. So, you've now been doing RFA for a while. Do you think that plays a role too? Like the longer someone's been doing it, the
Yeah,
better.
it's definitely a learning curve. I mean, even from when I first started doing biopsies in fellowship, I mean, it takes a while to get good at it. I mean, fellowship was a long time ago, so this is a little bit different. But yeah, the more you do them, you kind of get, what to look out for. People, uh, potential issues during the procedure, whether it's the generator issue or um, issues with the electrode. I mean, there's so many steps involved that to say you're an expert right out the gate is very naive. So we've been doing them here in my office now since 2019. So it definitely is a learning curve. But like with anything, I mean,
Yeah. Yeah. No, I understand. And any other risks or side effects that people should be aware of with RFA?
yeah, I mean, the most common side effects right after the procedure is include tenderness. I mean, we've been working on an area in your neck up to like a half hour, 45 minutes. It's going to be a little tender. Some temporary hoarseness is not uncommon. Not talking voice loss, but just some hoarseness, some bruising in that area. It shouldn't be bruising all over your neck. It should just be some localized bruising that may extend up and down the length of your thyroid area. Um, Sometimes patients have a little bit of a burn mark there because from the electrode going into the thyroid itself. Those are the most common side effects. Very rare side effects. The most rare is that recurrent laryngeal nerve injury. Um, Less also rare is something called capsular rupture, which that happens when people are over ablating a nodule for too long. So essentially, the capsule gets disrupted. Um, so that's why we keep the ablation times within the time period.
And do you do in your office ethanol ablation? There's
Yeah,
Yeah. Can you talk about I know there's ethanol ablation, there's laser ablation, maybe
right,
compare the different types. And I think ethanol ablation is more for cysts. Is that correct?
right. So ethanol, percutaneous ethanol injection, or you might see it termed PEI. Those are great for mostly cystic nodules. So those are the nodules that just are mainly filled with just fluid. Uh, so essentially, with the PEI, we drain out the fluid. Now, oftentimes, people who've had cystic nodules know that these nodules will fill up. They'll have been through this before. They'll have been through a biopsy where, oh, they said they aspirated everything and then it grew right back. These are the people that work really well for the PEI, or even just a just fluid filled nodules. So essentially, with a PEI, we also use the ultrasound for guidance. We drain out the fluid as much as you can. Oftentimes, I'll leave a little pocket because that's where I'm going to put the alcohol in. So we use a special kind of dehydrated alcohol. What that does is it fibroses the inside of that nodule down so that it does not fill up with fluid again. So that's a pretty quick procedure. That one probably is closer to the time, even less than a biopsy. Pluses of PEI, super simple. We might need to do another PEI if it does fill up a little bit. Some of these really large nodules, you think you got as much as you could out as far as aspiration, and they find a way to just fill up a little bit more. So we do sometimes have to redo it. Um, and it can sometimes burn a little bit depending upon the air where the nodule's at. Um, but that's about it. As far as like laser is great for larger nodules, it's a little more cumbersome than RFA. So RFA, we're using like a probe. It's a fine needle tip that I can go right in each and every section of the nodule. So laser is more like diodes. There's like a few diodes that go into the nodule. You don't have as much control. But some people, I don't do laser, but some people do really well with laser. When we look at head-to-head studies, RFA is still superior in efficacy than laser.
Okay. Yeah, I don't see a lot of research, at least compared to RFA. It seems like there's a lot more with RFA and thyroid nodules.
Not as much, not as much. But there are practitioners that do laser, and they have good results. Um, so we at our clinic we just only do PEI or RFA.
And with the PEI, so that's just for cystic nodules. If someone has a solid nodule, they then pretty
It
much.
doesn't work as well. I mean, there are studies on more heterogeneous or complex nodules. It's not as good. You can like instill as much alcohol into those nodules, and they're just going to laugh at it, and they'll be like, no.
Yeah. Okay. All right. Well, is there anything else that you'd like to discuss, or anything I didn't ask you that I should have asked you?
Sure. Probably some people ask who's a good candidate for RFA and who would not be a good candidate. So candidates that are really good are people who have a nodule that's bothersome, whether it's cosmetic, where you see it from the outside, whether it's compressing, like compressing on the sometimes very large nodules compress on the windpipe and can make breathing difficult or make swallowing difficult. If some of these nodules, when they're very large, like when you're lying flat, you can't breathe, or you have trouble like exercising because they're just pressing on the windpipe. These people are great candidates for RFA. People who've had previous lobectomy and they don't want to damage or lose the thyroid function they have in the remaining thyroid. This is being looked at for recurrence of thyroid cancer, so that's something to consider. And there's people who are really afraid of surgery or just don't want to have surgery. These are people that are good for RFA. So that's kind of the list of potential good candidates. People who really aren't ideal candidates are people who have pacemakers or defibrillators or have severe heart disease or on blood thinners that can't be stopped for a couple days before the procedure, and patients who are pregnant. So as of right now, those are probably not the best candidates.
Okay, so it sounds like getting back to like if someone has a partial thyroidectomy and then they have some nodules on on the thyroid that's left, the half of the thyroid that's left, they can undergo RFA rather than get the other half of the thyroid removed.
Yeah, because if that thyroid's working well, I mean, if you want to preserve what you have, like saving the rest of your thyroid rather.
All right. Well, this was wonderful. Again, I was really excited to chat with you about RFA, and I'm sure we're going to hear more and more about it in the future. But I think again now it's a really good option for a lot of people who are you know potentially facing thyroid surgery, just because there are still a lot of endocrinologists who aren't aware of it. I mean, is it safe to say that the average endocrinologist, they're not aware of it, or maybe they are aware of it, but just aren't too familiar with it? So that's why still a lot of endocrinologists are going to recommend the surgery route.
Yeah, I mean it's kind of mixed. I think I honestly think that a lot of endocrinologists don't know about it, and I think some endocrinologists are waiting for more data. Although there is a lot of data already on it, but they're not convinced because they haven't seen enough patients go through it to say, all right, well, I had this patient who had RFA, they did great. So, and I think the more we get the word out about it, the more we educate other providers about it, I think it's going to be more and more acceptable because they'll see the results are really good. And if patients themselves had an option, I think they would prefer not to have surgery rather than surgery if it was all feasible. Um,
Yeah, I agree. And one thing I hate mentioning it here, but I think I feel the need just, you would hope that in most cases, endocrinologists are going to do what is best for the patient. But, my guess is also surgery is a lot more profitable than RFA. And so,
Yeah,
again, you would hope that's not why they're recommending surgery. But, as
yeah,
RFA becomes more popular, you would hope again more. And I think you will see more and more endocrinologists
I think so.
incorporating it or referring out. But still, I'm sure there are some that just, hey, I don't know how much average surgery, is thyroid, but compared to RFA, it's, yeah. So anyway,
Right.
I just wanted to
I,
bring, not to say that most endocrinologists have that motive, to make money off the surgery, and that's why they recommend radioactive iodine. Radioactive iodine probably isn't that profitable compared, but
yeah,
but
no,
the
I
surgery, I
guess,
imagine it's
and if you're in a hospital-based practice, maybe they would want internal referrals. But I mean, if you're coming to an endocrinologist, I feel like we should be able to give all the options. If you're going to an ENT or a surgeon, I mean, I get that's they're gonna recommend surgery. I mean, because
that's what they do. Yeah,
that's what they do. But as I mentioned too, when we were speaking earlier, right now, this is all very patient driven. I mean, patients who are being proactive about their health and wanting other options. These are the patients that are going for the RFA because they know that surgery is not what they want and they want other options. So even when their doctors are telling them get the surgery, they're finding more research.
all right. Well, again, thank you so much, Dr. Mazza. And
Oh,
where can
okay.
people find out more about you? If you could share your website. I know you also have your
Sure.
own podcast as well.
Yeah, yeah. So my clinic and our website is metaboliccenterforwellness.com. We do have a podcast. It's like a once monthly. It's me and my friend Dawn, who is a friend as well as patient. So she gives a patient's perspective. It's called Thyroid Talk with Dr. Angela Mazza. We try and make it fun. I mean, as fun as certain topics can be, right? So.
Yeah, I've
Um,
listened to a few episodes. Yeah,
we're
I enjoyed it.
a little silly sometimes, but what are you gonna do? But yeah. So and then I have a YouTube channel. It's just Dr. Angela Mazza YouTube channel.
All right, wonderful. I'll make sure to include those links in the show notes. And yeah, again, thank you so much. It really was a pleasure chatting
Oh,
with you
thank
about RFA.
you. Thank you so much. I really appreciate the invite.
All right, so questions. If there are questions, I know there's right now there's one. So let me bring up the question here. Um, So I know what my thoughts are on RAI if there's no nodules, but and again, I'm not against. I mean, I'm like you said, there's a time and place for thyroid surgery. Radioactive iodine, again, I say sometimes if I had a choice between surgery and radioactive iodine, I'm pretty sure I would choose the surgery. I just don't like the thought of the
Yeah.
radiation, but not to say there's not a. But anyway, let's get your thoughts as far as if someone has, I guess in this case, maybe they have hyperthyroidism, Graves' disease, and the endocrinologist is
Says
because they don't really say
radioactive.
the situation here. So I'm assuming they have
Right.
hyperthyroidism, Graves, and
Uh,
maybe their endocrinologist is recommending radioactive iodine.
yeah, I here's my take on because I'm assuming this is a Graves' disease. If So with radioactive iodine, even in the setting of Graves' disease, you have a risk of developing hypothyroidism. You have a risk of needing another treatment, and then you have a risk of um, those are your two options, right? So, or there's a small chance that everything's going to settle out into normal range, and we live happily ever after. That just doesn't rarely happens. Now with Graves' disease, if we give radioactive iodine, no matter what, you can't take it back. If you do surgery, you can't take it back. But at least if you start the anti-thyroid medications as well as alongside, depending upon level of stability, maybe some integrative therapies along with it, um, you actually have the chance of one getting someone on as little or no thyroid medication because oftentimes Graves, if we get everything in balance, you become normalized or euthyroid. There is that chance. Yes, there's a chance that you may need to restart anti-thyroid medications in the future if things get flared up. But that gives you, that's an option. But once you give radioactive iodine, you can't take it back. So I tend to not go that route unless absolutely necessary.
Yeah,
But
I
that's,
agree.
yeah,
Again, yeah, just yeah, I couldn't have said it better. Once you get it, you can't
you
undo
can't
it,
take it
but
back.
you can always get it. If it absolutely, you just decide to get it. I would, just for anyone who I'm working with, or if you're working with someone, both of us, I'm sure we would want people to be comfortable with the decision and not have regrets like 6 months later. Oh, I wish I would have
Right. You
something
won't
else.
believe, you wouldn't believe, and I'm sure you hear it as well. The number of people that come to me from other physicians or from other practices or other experiences and who've had radioactive iodine and surgery and say, I wish I never had that.
Yeah.
And it's like, I can't, we can only try and make things as good as we can right now. But that hindsight regret, that's, especially when you know there's other, later on you find out there's other things you could have chosen. That's kind of tough. But
I agree. One question I have for you that we don't see much in the United States, but the ideal situation, like you said, is like someone, if they have Graves and if they have to take the antithyroid medication temporarily, but eventually they might not need it. But I know in some, I mean, I'm sure even some endocrinologists, maybe in the United States, but I see it a little bit more in other countries where, like if they're not opposed to keeping someone on a low dose of methimazole, like 5 milligrams. Whereas here, a lot of endocrinologists say, okay, we're only going to keep you on it for 18 months, 2 years. And if you're not in remission, then we're going to, again, that's when you need the surgery or radioactive iodine. Or if you relapse, you have to have the radioactive iodine thyroid
mhm.
surgery. But again, it's not an ideal situation. But I think if I had the choice to be on low dose methimazole or get radioactive iodine thyroid surgery, I think I'd want to be on the low dose methimazole, even though that's not addressing the cause of the problem. But honestly, neither is the surgery or the radioactive iodine. So,
Exactly. Yeah, you're exactly right. And we actually have studies that show that unless you're having an issue with, so a complete contraindication with methimazole or even propylthiouracil is if you develop like a decrease in your white blood cells, red blood cells,
mhm.
or liver toxicity. If you're not having any of those things, we actually have some good data that shows that you can maintain on antithyroid medications for long periods of time. So those days are gone, but some people sometimes that's still the recommendation. And I agree. I'd rather be on a low dose of one of those rather than, again, you can increase the dose if you're not having any issues and you're happy. It's not, but you can't take back the surgery and radioactive iodine. So yeah, you're exactly right. There's really no harm, and it's been proven now.
Yeah, thanks for that. Yeah, of course, if someone is having elevated liver enzymes, or like you said,
That's a
depressed
whole
white
other
blood cell
story.
count, or if they're just having other symptoms and side effects where they're just not feeling good, I could understand opting for something else. And do you see sometimes where people don't tolerate the methimazole, but they're okay on the PTU, where they tolerate the
Yeah,
PTU, all right?
I, I've had that happen. I actually have one or two patients right now where the methimazole, for some reason or another, just didn't agree with them. I think one of them had a rash to methimazole, but they did fine on just, even believe it or not, even though propylthiouracil should be dosed 3 times a day, ideally, just once a day, like a small dose, and that's keeping everything level. So yeah,
All
it
right.
just
Yeah.
goes to prove everybody's different. That's kind of the art of medicine, I suppose. It's not a one size fits all.
Yeah, exactly. I mean, I know there's people who also who it doesn't make a difference if they take methimazole or, um, PTU. They might have skin rashes or other side effects, or again elevated liver
Right.
enzymes, regardless. And it looks like I know Violet here says good afternoon, and good afternoon to you too, Violet.
Oh,
If there's any other questions, let us know. One thing that also came to mind. Do you have any experience with cholestyramine and hyperthyroidism, or?
a little bit. I know it's kind of on our list of integrative therapies that we can use. I've never had to use it, so
Yeah,
It
I've had
shows
I've had a
potential, but
few. I've had a few patients
really?
who just they couldn't.
The-
I mean, I don't have prescribing rights, so I couldn't prescribe it. But where they just couldn't tolerate the anti-thyroid medication, whether it's the
really?
methimazole and PTU, and then they were facing surgery, radioactive iodine, and there's I don't know how much you know about herbs, but when I dealt with Graves and I took bugleweed and it actually worked really good in
Oh,
my
great.
situation, but it doesn't work with everybody. So if someone is in a situation where they can't tolerate the antithyroid meds and the herbs just aren't effective, the cholestyramine, I can't say I've
That's
had
what
a
they go
large
to.
number of people, maybe at this point, maybe now like 5 or 6 people, which is a very small sample size. But I think everybody who has taken it, it's helped with the lower the thyroid hormone levels. And again, a lot of
Well,
endocrinologists are still, I mean, some of them aren't familiar with it with regards to hyperthyroidism, but, I've had a few tell patients, well, it's not doing anything, it's not helping to improve the person's health, or I forgot the excuse, but really the methimazole isn't doing anything to,
no, it's just
to,
blocking the thyroid. But I mean,
yeah,
the cholesterol is going to help metabolize out the thyroid hormone. So I mean, it makes complete
yeah.
sense.
But yeah, I mean, I've had some people do really well, and again, it's
That's
just
good to
I guess if
know.
anything, buying time and just you know, yeah. Anyway, so I just
Another
wanted to
tool
know
in the
your
toolbox. So it's always nice to have something else.
yeah, yeah. And there's some studies also that back it up too. So I just tell them just I have some research on my website, so I just say bring don't tell them that I told them to take choice. They don't want to hear
Just say a little birdie.
yeah, but if they go to, the journal articles and they show them this, the few studies that show that
Right.
cholestyramine can help with hyperthyroidism, they might be open. I've had a few endocrinologists who are like, all right, I'll, give it a try. And so,
What's the harm? Yeah.
yeah, but, all right. Well, looks like again, it looks like we're out of questions. So again, thank you so much for
Thank
for
you.
doing this, Dr. Mazza,
Of
and
course.
thanks everybody for your questions. And yeah, definitely reach out to Dr. Angela if you have if you have interest in radio frequency ablation. And can you one more time give that website address?
Sure. It's metaboliccenterforwellness.com.
Okay, metabolic center for wellness.com. And again, that'll be in the show notes when this is on the podcast. And thanks again. Yeah,
Thank
again, this
you.
this was wonderful.
Oh, thank you. This was a lot of fun. I appreciate the invite.
Yeah, and take care, everyone. Have a great rest of your Friday and a great weekend ahead.